This is Duke University.
This also kind of talks about trends in mental illness and treatment worldwide, and how the movement of ideas about mental health and mental well-being have kind of been transmitted across international borders, both historically and today. Mike Merson, the longtime director at the DGHI, gave a really excellent talk in the spring on what he termed the future of health. He talked about some trends, and I think broadly you could kind of lump these together in terms of globalization. That as the world becomes more developed, we'll see improved life expectancy, reduction in poverty worldwide, increased commercialization and urbanization globally, and then some ongoing challenges that are related to kind of the growth of population and urbanization, including climate change and ongoing war and conflict in countries. So these all certainly have an impact as well on kind of the flow of health and ideas about health. We can't presume to teach until we've learned first, and that people are the experts on their own personal and cultural contexts, and we should seek to learn from them before we ever seek to promote ideas about health, well-being, and programs related to health. And trending away from more short-term kind of parachute models where you're dropping in, learning about a context, doing a research project, maybe doing a short intervention and leaving, instead longer-term models that are really based in the local community. So if we think about it in the case of mental illness, how does it apply? How do we kind of think about mental health treatment in this international context? Well, we have to ask ourselves the question of, are mental illnesses universal, right? Are they seen the same way across contexts and across geography, across regions? And what we know is that the answer is generally no. We don't often think about mental illness as a form of contagion. It's not germ-based, right? But that the ideas we have about mental illness can actually transmit across international borders, and that we have to be careful about promoting treatment because we might actually be promoting a different idea of the disorder as well. So on one hand, we have the idea of caution, of kind of taking a measured approach, understanding the context before incorporating treatment. On the other hand, we have the perspective that half of the world has no treatment at all and that we need to increase access. You'll notice that the language there kind of goes back to that provide language, that some of us have it, others don't, and those who have it have a moral responsibility, essentially, to provide it to the other. In measuring the differences in impact of different treatments in mental health, a lot of research has emerged kind of arguing that it's not the type of treatment or even the techniques that we offer that create differences. What creates differences is these kind of common factors in psychotherapy, that if you are a caring person who provides a caring setting for somebody to kind of get treatment and care, that's the number one and most important factor that will impact their outcomes. On the other hand, we have this vast repository of programs and projects and interventions that have been proven evidence-based. And so who's right? Well, it's a both and. That of course we need to provide the right circumstances for people to have access to treatment and to improve. But when we see specific situations that require specific interventions and those have been proven to be effective, we have to apply those as well. So the same is true, I think, of this kind of idea of cultural relativism versus the movement towards global mental health, increasing access as much as possible and as quickly as possible. That both are true, that we, of course, need to provide access to care if it's available, but of course we need to be mindful of the cultural applicability of these treatments as well and adapt them as effectively as we possibly can. Where should treatment occur? Where should it occur in an ongoing way? We've found that, at least initially, our investment might be best in these two on the right, in the school setting and the one on the bottom in the community setting, because of that stigma that I just described, that the stigma associated with seeking formal care is so great that it's really an uphill battle right now to even have people consider seeking that sort of care. So as we consider where to go with this in the future, we're continuing to kind of weigh the merits of a community-based model or a school-based model in these contexts of ways to kind of reduce stigma by offering programs supported by non-specialists. What we did find is that there is kind of a tension between the formal healthcare system and more religious and traditional models of care. And so when we're interviewing mental health providers in Tanzania, they're often saying that there are these traditional healers or religious healers who are out in the community, that they're charlatans, that they're trying to take advantage of people and tell them that they can cure them with faith. On the other hand, when we talk to the patients or the people who are experiencing care, they frame it much differently. They say that this is the source of support that my family has always gotten, and that it's more foreign to me to be kind of referred to this provider to talk to, that those are the people I feel more comfortable talking to. We talk about cultural humility, but this type of work also requires quite a bit of professional humility in giving away your expertise sometimes and saying that I may have this degree or that training, but oftentimes the people who are right there, who've been supporting these folks all along, are going to be a lot more effective than we are at providing this kind of care.